Hello friends, we are welcome back to Joan Academy. In this video we will be discussing the two bones of the upper limb, which are the clavicle and the humerus. We will take them one after the other. We will go with the clavicle first. The clavicle is also known as the collarbone. It extends between the manubrium of the sternum and the acromion of the scapula. It is classified as a long bone and can be palpated along its length. In thin individuals, it is visible under the skin. The clavicle has three main functions. It attaches the upper limb to the trunk as part of the shoulder girdle. It protects the underlying neurovascular structures supplying the upper limb. It transmits force from the upper limb to the axial skeleton. Let's look at the bony landmarks and articulations of this bone. The clavicle is a slender bone with its shape. Facing forward, the medial aspect is convex and the lateral aspect is concave. It can be divided into a sternal end, a shaft, and an acromial end. The sternal end can also be called the medial end. It contains a large facet for articulation with the manubrium of the sternum at the sternoclavicular joint. The inferior surface of the sternal end is marked by a rough oval depression for the costoclavicular ligament. It is a ligament of the sternoclavicular joint. The shaft of the clavicle acts as a point of origin and attachment for several muscles, which are the deltoid, trapezius, subclavius, pectoralis major, sternocleidomastoid, and sternohyoid. The acromial end of the clavicle can also be known as the lateral end of the bone. It houses a small facet for articulation with the acromion of the scapula at the acromyoclavicular joint. It also serves as an attachment point for two ligaments, the conoid tubercle and the trapezoid line. Conoid tubercle is the attachment point of the conoid ligament, the medial part of the coracoclavicular ligament. While the trapezoid line is the attachment point of the trapezoid ligament, the lateral part of the coracoclavicular ligament. The coracoclavicular ligament is a very strong structure, effectively suspending the weight of the upper limb from the clavicle. Having done justice to the clavicle, let's look at the humerus. The humerus is a long bone of the upper limb, which extends from the shoulder to the elbow. The proximal aspect of the humerus articulates with the glenoid fossa of the scapula, forming the glenohumeral joint, which is commonly known as the shoulder joint. Distally, at the elbow joint, the humerus articulates with the head of the radius and trochlear notch of the ulna. Let's look at the proximal landmarks of the humerus. The proximal end humerus is marked by a head, anatomical neck, surgical neck, greater and lesser tuberosity, and intertubercular sulcus. The upper end of the humerus consists of the head. This faces medially, upwards and backwards, and is separated from the greater and lesser tuberosities by the anatomical neck. The greater tuberosity is located laterally on the humerus and has anterior and posterior surfaces. It serves as an attachment site for three of the rotator cuff muscles, which are supraspinatus, infraspinatus, and teres minor. These muscles attach to superior, middle, and inferior facets, respectively, on the greater tuberosity. The lesser tuberosity is much smaller and more medially located on the bone. It only has an anterior surface. It provides attachment for the last rotator cuff muscle, which is the subscapularis muscles. Separating the two tuberosities is a deep groove, known as the intertubercular sulcus. The tendon of the long head of the biceps brachii emerges from the shoulder joint and runs through this groove. The edges of the intertubercular sulcus are known as lips. Pectoralis major, teres major, and latissimus dorsi insert on the lips of the intertubercular sulcus. This can be remembered with the mnemonic "a lady between two majors," with latissimus dorsi attaching between teres major on the medial lip and pectoralis major laterally. The surgical neck extends from just distal to the tuberosities to the shaft of the humerus. The axillary nerve and circumflex humeral vessels lie against the bone here. From our explanation so far, we can see that at the proximal aspect of the humerus, the sites of muscle attachment are the greater and lesser tuberosities. Let's look at the shaft of the humerus. The shaft of the humerus is the site of attachment for various muscles. Cross-section views reveal it to be circular proximally and flattened distally. On the lateral side of the humeral shaft is a roughened surface where the deltoid muscle attaches. This is known as the deltoid tuberosity. The radial groove is a shallow depression that runs diagonally down the posterior surface of the humerus, parallel to the deltoid tuberosity. The radial nerve and profunda brachii artery lie in this groove. The following muscles attach to the humerus along its shaft. Anteriorly, we have coracobrachialis, deltoid, brachialis, and brachioradialis. Posteriorly, we have medial and lateral heads of the triceps. Let's have a look at the distal region of the humerus. The lateral and medial borders of the distal humerus form medial and lateral supraepicondylar ridges. The lateral supraepicondylar ridge is more roughened, providing the site of common origin of the forearm extensor muscles. Immediately distal to the supraepicondylar ridges are extracapsular projections of bone, the lateral and medial epicondyles. Both can be palpated at the elbow. The medial is the larger of the two and extends more distally. The ulnar nerve passes in a groove on the posterior aspect of the medial epicondyle, where it is palpable. Distally, the trochlea is located medially and extends onto the posterior aspect of the bone. Lateral to the trochlea is the capitulum, which articulates with the radius. Also located on the distal portion of the humerus are three depressions known as the coronoid, radial, and olecranon fossae. They accommodate the forearm bones during flexion or extension at the elbow. Let's look at the articulations of the humerus. The proximal region of the humerus articulates with the glenoid fossa of the scapula to form the glenohumeral joint, which is commonly known as the shoulder joint. Distally, at the elbow joint, the capitulum of the humerus articulates with the head of the radius, and the trochlea of the humerus articulates with the trochlear notch of the ulna. Let's look at the clinical implications associated with these bones. Some of the important clinical implications include fracture of the clavicle, surgical neck fracture, midshaft fracture of the humerus, and supracondylar. For fracture of the clavicle, it is important we note that the clavicle acts to transmit forces from the upper limb to the axial skeleton. Because of its size, it makes the bone susceptible to fracture. The most common mechanism of injury is a fall onto the shoulder or onto an outstretched hand. With the clavicle arbitrarily divided into thirds, 15% of fractures occur in the lateral third, 80% occur in the middle third, while the other 5% occur in the medial third. After a fracture, the lateral end of the clavicle is displaced inferiorly by the weight of the arm and displaced medially by the pectoralis major. The medial end is pulled superiorly by the sternocleidomastoid muscle. Management of a clavicular fracture can be conservative, like sling immobilization, or it can be operative, like open reduction and internal fixation. The supraclavicular nerves lie in close proximity to the clavicle and are occasionally sacrificed during a surgical repair, resulting in a numb patch over the upper chest and shoulder. As for the surgical neck fracture of the humerus, the surgical neck of the humerus is a frequent site of fracture, usually by a direct blow to the area or falling on an outstretched hand. The key neurovascular structures at risk here are the axillary nerve and posterior circumflex artery. Axillary nerve damage will result in paralysis to the deltoid and teres minor muscles. The patient will have difficulty performing abduction of the affected limb. The nerve also innervates the skin over the lower deltoid, which is the regimental badge area, and therefore sensation in this region may be impaired. For the mid-shaft fracture of the humerus, there is a risk of damage to the radial nerve and profunda brachii artery, the reason being that they are tightly bound in the radial groove. The radial nerve innervates the extensors of the wrist. In the event of damage to this nerve, either direct or as a consequence of swelling, the extensors will be paralyzed. This results in unopposed flexion of the wrist, known as wrist drop. There can also be some sensory loss over the dorsal surface of the hand and the proximal ends of the lateral 3.5 fingers dorsally. A supracondylar fracture, on the other hand, is a fracture of the distal humerus just above the elbow joint. The fracture is typically transverse or oblique, and the most common mechanism of injury is falling on an outstretched hand. It is more common in children than adults. In this type of injury, the brachial artery can be damaged either directly or via swelling following the trauma. The resulting ischemia can cause Volkmann's ischemic contracture, which is an uncontrolled flexion of the hand as flexor muscles become fibrotic and short. There also can be damage to the anterior interosseous nerve, ulnar nerve, or radial nerve. The anterior interosseous nerve can be tested by asking the patient to make an OK sign, testing for weakness of flexor pollicis longus. The Gartland classification is used for these fractures. Type 1 is minimally displaced. Type 2 is displaced but with an intact posterior cortex. Type 3 is completely off-ended. Type 1 can usually be managed conservatively with an above-elbow cast, whereas types 2 and 3 typically require surgical fixation with crossed bicortical K-wires. I hope you found this video helpful. Subscribe to Joe Academy for more.